I am going to talk on management of dengue fever in children. First, see the introduction. Most common and important vector-borne disease in the world. It is also known as breakbone fever because of the deep muscular and joint pain. It is caused by dengue virus. It is RNA stranded, single stranded RNA virus, came under the family of flavivirus. It is caused by bite of the female Aedes mosquito. Why only female? Are they blood suckers? No. No. Require human blood for maturation of the eggs. There are 4 main serotypes, that is dengue virus 1, type 1, 2, 3 and 4. Then let's see the epidemiology. Dengue fever is mainly found in the tropical and subtropical countries in the world. More than 120 countries involved with the dengue fever. More than 400 million people are exposed to the disease. In India, it's found in all states and union territories except sub-Himalayas and sub-Himalayas regions. See the pathophysiology of the dengue virus. Dengue virus is mainly affect the three tissues. That is, first the hematopoietic precursor cell, which leads to the suppression of the bone marrow, causes leukopenia and thrombocytopenia. Second tissue is the endothelium. The dengue virus, which causes endothelial damage, leads to the plasma leak, which causes hypovolemia and shock. Third is the platelet. Dengue virus, which attaches the Archie receptor of the platelet, which leads to the secretion of the ADP. ADP is the strong aggregator of the platelets, which leads to the disseminated intravascular coagulation and thrombocytopenia. Then see the case classification. Case classification is very important for the monitoring and treatment of the dengue fever. These are classified into the mild dengue fever, moderate dengue fever and severe dengue fever. Mild dengue fever, it is very difficult to differentiate mild dengue fever from the other viral infection. How will you define the suspected dengue fever? Fever associated with following 2 manifestations, that is headache, retroorbital pain, rash, arthralgia, myalgia, leukopenia, count less than 5,000 count, 5,000 thrombocytopenia less than 1.5 lakh international unit, and tourniquet test positive. In moderate dengue fever, how will you define the moderate dengue fever? The dengue fever associated with warning sign and comorbidity. Warning signs are the severe abdominal pain, persistent vomiting, hepatomegaly, altered sensorium and convulsions, and restlessness, irritability, minor bleed like gum bleeds, melena and epistaxis. And hematocrit is more than 20% of the basals. Comorbidities are very important because dengue virus associated with the comorbidity easily go into the dengue shock. These are the infant, obese child, chronic hepatic diseases, secondary dengue fever, bronchial asthma, diabetic mellitus, other hemoglobinopathies. Then the severe dengue fever. Severe dengue fever is classified into dengue shock syndrome, hemorrhages, that is a gastrointestinal bleeding, pulmonary hemorrhages, intracranial hemorrhages, or severe hematuria. Sometimes severe other organ involvement. World Health Organization classified as severe organ involvement into the expanded dengue syndrome. These are the phases of the dengue fever, mainly 3 phases, that is febrile phase, critical phase and recovery phase. Febrile phase, it lasts up to 3 to 7 days of the illness. Child present with the high grade fever, some young children and infant present with the febrile convulsions. Critical phase, it remains for 24 to 48 hours only. In the critical phase, there is a plasma leak, there is hypovolemia and shock. Sometimes in critical phase, child present with severe hemorrhages and severe organ involvement. In recovery phase, there is extravascular fluid is absorbed into the intravascular space. If child is bloating, then sometimes they goes into the pulmonary edema. Diagnostic test. How will you diagnose the dengue fever? Dengue fever will be diagnosed with detection of the virus, viral particle or antibody against the dengue virus. Virus isolation by the viral culture. It is done at the National Institute of Virology at the Pune. Genetic detection by the polymerase chain reaction. Detection of the NH1 antigen and antibody against the dengue virus, that is IgM, IgG, by card kit test or ELISA test. World Health Organization not recommended the CAR test because there is high possibility of false positive and false negative results. So you have to do test with the ELISA method. Dengue fever is the notifiable disease. You have to notify disease to the government authority. So if you are done the test by the CAR test, you report as only suspected dengue fever. Don't report as dengue fever. Unless if you done this test by ELISA method or PCR method. Polymerase chain reaction detection is this test is not easily available and very expensive. Then see the management of the dengue fever without warning sign, that is in the febrile phase. You have to encourage the oral fluid. You have to give the oral fluid as which are rich in the electrolyte rich solution, that is oral rehydration solution and coconut water. If child is febrile, you have to give antipyretic, that is paracetamol only. Dose is 10 mg per kg per dose, that is less. You have routinely used like 15 mg per kg per dose. There is a possibility of hepatitis in the dengue fever. You have to restrict the dose, that is 10 mg per kg per dose. When required the admission of the child in the febrile phase. If child is having repeated vomiting, dehydration, child is not taking orally, parents are not capable of monitoring of the child in the home, that is illiterate parents, or child stay away from distance from the medical facility. This child you have to admit for the monitoring. When to start the IV fluid in the febrile phase? You have to start IV fluid if the child is taken orally. Try to restrict the, try to avoid the IV fluid. Use only if required IV fluid. You use only those child are dehydrated, not taking orally. You have to start the IV fluid. You have to use as isotonic saline. Don't use hypotonic saline like isolate P or half DNS. Fluid should be given cautiously in the dengue fever. So this figure is very important. You have to give fluid as controlled infusion manner. So you have to use a dial flow or infusion pump. Yet the cost of the dial flow was only 75 rupees. And second thing is you have to collect the urine. Urine output is very important. You have to collect in the urine in the empty Bisleri bottle. Don't require catheterization in mild and moderate dengue fever. It's required only in severe dengue fever. So you have to give IV fluid in the drip with the infusion, that is only 1.5 cc per kg per hour. Don't use, it is very less much than the maintenance fluid. Maintenance fluid is 4 cc per kg per hour. You have to restrict the fluid because this excess fluid give trouble in the critical phase and it boomerang in the critical phase. Monitor the warning signs and do the basal hematocrit platelet count in this phase. Then the treatment of the moderate dengue fever, that is dengue fever with warning signs. How to detect the dengue fever with warning signs, and there is plasma leak in this phase. So how to detect the plasma leak by laboratory evidence? You have to do hematocrit. If hematocrit is more than 20% or serum albumin less than 3.5%, you have to do X-ray to see the pleural effusion and do the ultrasonography to detect any ascites or gallbladder edema. How to treat patient with the warning sign? Start the fluid as 6 cc per kg per hour normal saline. It gives for 1 to 2 hours, monitor 3 things, that is hematocrit, vitals and urine output. If hematocrit is stable and urine output more than 1 cc per kg per hour and vitals are normal, you have to step down fluid within 2 hours. Don't give more than 2 hours in warning sign if the vitals are stable. You step down to 3 cc per kg per hour, then 1.5 cc per kg per hour. How to treat dengue fever with compensatory shock? What is compensatory shock? Here blood pressure is normal, but child present with the tachycardia with poor peripheral perfusion, that is CRT is more than 3 centimeters. You have to start the fluid as 10 cc per kg per hour and monitor same vitals, hematocrit and urine output. It's give only for 1 hour and monitor the vitals. If vitals is improved and urine output is adequate, it step down to 6 cc per kg per hour, then 3 cc per kg per hour, then 1.5 cc per kg per hour. And if child is not improving after 10 cc per kg per hour, that is in first hour, you have to give again 10 cc per kg per hour for 2 hours. But in recent Indian Pediatric Academic Standard Guidelines, they suggest after 1 hour give the colloids, that is 10 cc per kg per hour. Colloid, which is choice of the colloid. Mainly 5% albumin is the choice. Why not 20%? Resuscitation fluid of the albumin is 5%. You have to treat, you require but treatment for hypoalbuminemia, then use the 20% of the albumin. If albumin is not available, then use the dextran 40. If the child's hematocrit is dropped, but vitals are not improved, then suspect the occult bleed and give the blood transfusion. Then management of the dengue shock syndrome. How will you diagnose dengue shock syndrome? What is definition? There is systolic blood pressure less than 5th percentile for particular age and height. Or if sometimes systolic blood pressure is normal, but pulse pressure is less than 20, that is difference between systolic and diastolic blood pressure is less than 20, then it's also labeled as shock. Third is there is absent peripheral pulsation. Just start the fluid at 20 cc per kg per hour over 15 to 30 minutes. It is an infusion bolus, not the push boluses here. You have to give infusion here. What is difference between dengue shock syndrome and septic shock? Fluid resuscitation difference. In septic shock, you have to give 10 to 20 cc per kg, 3 pushes within 10 minutes. But here you have to give infusion boluses, not the push boluses. That is over 15 to 30 minutes. And if child is not improved, you give 20 cc per kg NS over 15 to 30 minutes, and third is 20 cc per kg per hour. When IMP standard treatment guidelines recently came, they said second and third bolus should be preferably colloids, that is 5% albumin, that is 10 cc per kg per hour over 2 hours. If hematocrit drop but vitals not improved, then suspect the occult bleeding and give blood transfusions. Then if child is improved with 20 cc per kg per hour, you have to step down the fluid at 10 cc per kg per hour, 6 cc per kg per hour, 3 cc per kg per hour, then 1.5 cc per kg per hour. You don't jump from direct child is improved from 20 cc to 3 cc. You have to stepwise titrate the fluid stepwise. If child is not improving after boluses, infusion boluses or colloid resuscitation, then what to do? It's labeled as refractory shock. You see the A, B, C, D, E. That is A for acidosis. If there is acidosis, treat with the soda bicarbonate. B for bleeding. If there is bleeding, give blood transfusion. And C for calcium and D for dextrose. If there is hypocalcemia and hypoglycemia, you have to treat that. E also is there but not written here. E for echo. You have to do 2D echo to rule out the myocardial involvement or myocarditis. Why only hypotonic? Why the only isotonic? Why not hypotonic fluid? The hypotonic, that is hypotonic fluid remains intravascular only 10%. And you give the isotonic fluid, then it remains 25%. And colloid 100%. Why not the colloid first choice of the treatment? In dengue, there is not only the plasma leak, it also protein leaks. If give the colloid in the first stage, the colloid also leaks, which increases the osmotic pressure extravascularly, also leads to the increase the capillary leak. So you have to avoid in initial stage colloid. In dengue fever, fluid is a double-edged sword. If give excess, it trouble in the critical phase. That is, it increases the ascites and pleural effusion, leads to the respiratory decompromisation. And if give less, then child go into the dengue shock syndrome. You have to balance fluid, like balance walking on the tight ropes. Management of the bleeding in the dengue, causes of the bleeding in the dengue fever. Most common cause of the bleeding in the dengue is the shock, not the thrombocytopenia. Second is the disseminated intravascular coagulation. Third is the thrombocytopenia. Liver involvement causes liver derangement, leads to the bleedings. And heparin-like substance released by the endothelium. First priority, correct the shock, because most common cause of the bleeding is shock, not the thrombocytopenia. If first priority, give the blood transfusion if the child is bleeding, and if PTP blood transfusion should be whole blood. If there is no respiratory rate, 10 cc per kg. Child present with respiratory distress, then you have to give 5 cc per kg. If the PTPTK is deranged and bleeding is not stopped, then again fresh frozen plasma. FFP is a colloid or crystalloid? It is colloid. It is naturally colloid. So you have to give in drip. Don't push the FFP because it leads to the pulmonary edema. So you have to give FFP over 1 to 2 hours. And lastly, platelet transfusion. Platelet transfusion. Dengue is not the platelet count disorder. So you have to, there is prophylactic platelet transfusion not indicated in the dengue fever. 5. There is a fluid overload, and second is it promotes the thrombosis. How it promotes the thrombosis? The endothelium, which release the wall, damaged endothelium release the wall membrane factor. And wall membrane factor inhibited by Amstrad R3 enzymes. In dengue, there is deficiency of that enzyme. Wall membrane factor circulate in the blood. If you give her the platelet, that attaches to a platelet and which causes the thrombosis. So you have to avoid the platelet transfusion in the dengue fever. When it is indicated, there is severe thrombocytopenia, less than platelet count less than 10,000, or there is a bleeding in spite of blood and fresh frozen plasma. Take home messages. In febrile phase, increase the oral fluid, try to avoid the IV fluid in the febrile phase. If dehydrated, child is dehydrated, give only 1.5 cc per kg per hour. Don't use 4 cc per kg per hour as maintenance. And monitor the vital signs. In critical phase, use the judicious crystalloid and keloid. Don't give push boluses. Remember, infusion boluses, you give the infusion boluses. If you give the push boluses, it troubles, that increases the ascites and pleural effusion if you are given boluses. Use colloid in drip over 2 to 3 hours. Don't push the colloid because it leads to the pulmonary edema. Third, in recovery phase, stop the fluids. And if child is bloating and there is pulmonary edema, use the furosemide IV infusion. Don't push the Lasix directly. You have to give in infusion. Thank you very much.